Hello, dears, and welcome to Al-Hussaini Virtual Lab, Pathology Talks, Tips, and Practical Tips. Today, I'm going to continue on with the same theme as the previous two tips, and this time in relation to perforation in colorectal carcinoma. And how is this different than involvement of the circumferential resection margin? So perforation is defined as the involvement of the peritoneal surface as breaching of the serosa with the tumor cells visible on the peritoneal surface. So we have to see tumor cells at the peritoneal surface, perhaps sometimes separated from the peritoneal surface by inflammatory cells or a cellular mucin, or free in the peritoneal cavities. Either of these would establish the case as peritoneal involvement equal to perforation, and this would translate into PT4A staging. Remember, with CRM we're talking about PT3 staging because CRM is involvement of the non-peritonealized surface. This is considered to be a margin, while with perforation there is perforation of the peritonealized surface with the tumor cells flowing in the cavity, in the peritoneal cavity, and this would really equal PT4A staging. How does this really translate in cases? This is a recent case that I encountered, and you can see here the smooth peritonealized surface of the colon, and then suddenly there is this defect, and then here it continues back again to being smooth. Now we can see tumor gland, malignant tumor cells and glands are present here at what appears to be the perforation. How do we prove it if we are in doubt? I did calretinin immunostain, and then we can see calretinin, and in between the glands are actually dissecting and perforating and disrupting the peritoneal surface. Now CDX2 on the other hand would highlight the malignant glands, and they are really just in direct contact with the outer surface beyond the peritoneum, beyond the mesothelial lining. Now, in cases of doubt, you can utilize elastic stain, and this is the elastic lamina of that should normally be encountered or seen in the peritoneum, and we can see that the malignant glands are beyond, outside the this elastic lamina, which is completely disrupted here, and this would be also equal to perforation. So this case would be really signed as PT4A case. This is another more subtle case, and as you can see that the glands are really coming very close to the peritoneal surface, but the peritoneum has this mesothelial hyperplasia and fibrin is always an excellent clue to look for areas of perforation. You have to do deeper section, you have to take more sections from this area if perforation cannot be proven. And then again, malignant glands very close by to a peritoneum that is not shiny, that is dull, with fibrin, inflammatory cells, and mesothelial hyperplasia. And with calretinin, lots of hyperplasia of the sub-mesothelial cells, and there is one malignant gland, again on higher power magnification, really very supportive that there is perforation. And then there is another focus where the calretinin is positive in the mesothelial cells, and there is reaction beyond after the mesothelial cells into the peritoneal cavity, and then the CDX2 shows the malignant, scattered malignant tumor cells and poorly formed glands beyond after the calretinin positivity, which would be equal to perforation. Now, in this particular case, elastin was not really helpful. So remember that you can utilize calretinin and CDX2 to show or to support that this is perforation. Now, recently, there has been some advocate to use the term biological perforation to denote spontaneous perforation versus iatrogenic perforation, which happens at the time of surgery. Now remember, biological perforation is PT4A, Iatrogenic perforation, if it occurs while the tumor is intra-abdominal, is also considered to be PTA. However, if this perforation occurs outside the abdominal cavity, the tumor should be staged as PT3. I hope you find this tip useful in your daily practice. Thank you.